je naša sesija i ovaj posljednji Vasile iz Sofije. Lecture and topic.
Is it okay? Hello to everybody, and our pleasure to be here with you. Now, the first presentation, a little bit there is a change in the program, will be done by Professor Vasilev, who is the head of the president of the Society of the Interventional Cardiology of Bulgaria. And his presentation regards the ECG registration by the wire, intracoronary ECG during the interventional procedures. So we can start with his presentation, which is registered one.
Yes, the study about the application of ECG bifurcation lesions. We started 10 years ago with the procedure study with the aims of the detection of ocular secretion and temperature ischemia during the procedure. We also intend to detect the significant side effects associated with this method and to assess the sensitivity and specificity of this method to predict post-procedure drop in the eyes and eventually to localize the region of this post-procedure increase in myocardial necrosis. What we observed was that there was a linear correlation between the region of ischemia detected from the peaks of PCI wires and notice, so this is
Thank you. Is it working? No, as I understand, he is not online, the professor. This is it's a registration. He is not online, so we can say everything bad about the presentation. No, I'm joking. Well, I heard this presentation, that similar one from Vasilev some months ago, or I'm sorry, 2 years ago, during the European Bifurcation Club meeting. He presented his data about the intracoronary ECG registration. I remember that Patrick Sirius said that this is fantastic method, very cheap method to evaluate the procedure, bifurcation or not bifurcation, during the angioplasty, to see your result and to reduce the use of the contrast. Very cheap method, very easy to perform. I try to do it in my cath lab. This is the one wire, you put a wire with a cocodrile on the coronary wire, and then the other part you put on the ECG, precordial ECG on the monitor. It's working, but you know, but every time you have to resterilize it, and this is difficult to do in Italy. So we did it 2 or 3 times, and that was, but the method is okay. I think it's really very interesting, and I think even the Bifurcational Club, they're performing some study regarding the intracoronary ECG and some other markers about the effectiveness of the side branch results after the angioplasty bifurcation. Now, because we little bit changed the program, I give the word to our colleague from Costa Rica, Dr. Eric Sanchez, who is working in Italy. He will present an interesting presentation regarding the situations when angioplasty or the optimal medical therapy is not the option to resolve the problem of the patient. So what are the other interventional options when angioplasty is not possible, optimal medical therapy is not possible? So what we can do further. So Dr. Sanchez, welcome to Serbia, and we are glad to hear your presentation. Thank you. Please.
Hello, it's a pleasure to be here and present our work in Italy. Just a moment. You can visit Costa Rica, but it's very far away. 15 hours flight. Probably from here would be 15 hours, but from Italy, 11 hours. We will go. Okay. Okay, we're gonna start. As Dr. Fari said, we're gonna talk about the interventional procedure beyond the normal the normal procedure we do, CABG or PCI, and patients that have already all the medications possible. Okay, we're gonna start with a short case. This is a 72-year-old male, active, with hypertension, dyslipidemia, smoking, that presented with chest pain. You can see the vital signs are okay, not perfect, and those are the medications. As you can see in the, I hope you can see the videos. You can see the right coronary artery. It's a small caliber and some small vessel disease. Okay. And then here you can see in the rest of the videos an important severe lesion in the left main, but also some small artery disease in this, for example, this diagonal here. Okay, so of course the patient was rejected for CABG, and we decided to do a PCI. And this is the first images to show that we put the stent in the left main. We use a provisional side branch stenting strategy. Here is the deployment of the stent. We did a kissing balloon and a final pot, and good result. Here you can see that the last two pictures are the result of the angioplasty, and it's good. And also we also modify and optimize the medications, giving beta blocker and lipid lower therapy. The problem is that the patient came back 4 months later, and he had the history that visited the emergency room a couple of times. And as you can see, during the visit, the general cardiologist add some medications because the patient is still with pain. And you can see we repeat an angiogram, and this was 4 months after the PCI, and the stent is okay. The result is the same. You can see that the first diagonal is a little bit pinched, but it's a small artery. So what to do with these patients, right? That's a problem. So we're going to talk about what's the reducer. It's a stent, a metallic stent in a shape of hourglass. And you can see you have a pre-shaped balloon, a bigger proximal balloon and a distal smaller balloon. And in the mid, these two balloons or these sides of the stent, you can modify with the pressure, the inflation, but the mid part is the same, 3 millimeters. And this is a very simple device. It comes with a knife-range guide catheter, which is the delivery system. And you have 3 markers, one marker for the distal balloon here, I hope you can see, and another marker in the mid part for the proximal balloon, and also a marker here for delivery. So in order to talk this, we have to go back a little bit in the basics. So what do you have angina? Why you have angina? So you have to know that you can have a coronary artery disease due to the macrocirculation, or you can have a microvascular dysfunction due to the microcirculation. And most of the patients that you can see now, complex patients, have both. And here you can see some of the pathophysiology, but the main thing is that the microcirculation, it's with an increased tone. All the arteries, the arterioles are, the tone is increased. And so when we put a reducer, what is gonna happen? When you put a reducer here in the coronary sinus, you increase all the pressure backwards to the venous system, to the capillaries, to the arterioles. But the most important thing is that they found, some people, that there is an increase, or a vasodilation of all the microcirculation. And this increase also, at the end, increase the coronary blood flow through the epicardial arteries, even if you have a stenosis in the epicardial artery. Another interesting finding is that they found that, for example, in this picture in the A, you can see here is the epicardial artery, here is an stenosis, and here is another artery without a stenosis. Here are the capillaries, and you can see that if you restrict the coronary sinus, the capillaries that are without disease, vasodilate and improve bridges to the capillaries that are with disease. So you can see that the collaterals are with this pressure in the venous system. This coronary intervention is not something new. You can see that since 1948, Beck started to do a surgery connecting the aorta to the coronary sinus and bypassing arterial blood to the coronary sinus, and that improved life. But after this came the CABG, and of course that decreased. But this is not new information. As you can see here, the retroperfusion, then comes the retroinfusion in the cardioplegia used for coronary, for cardiac surgery, and now the new devices. So in the guidelines, there is an indication 2B for reducer here. It's indicated for refractory angina, for patients that you did all you can in a PCI in the cath lab, or or you did cardiac surgery and then PCI. You give all the medications, but the patient is still with symptoms. The evidence is not big. This is the first study in men in 2007, and it happens 7 years until the next study in 2014. After these two small studies, there was a trial published in New England Journal of Medicine. You could see a trial that they took 100 patients with similar characteristics with a class of angina 3 or 4, and they randomized to improve 2 or more classes of angina. We're gonna see here the results. So the primary endpoint was a reduction of 2 or more classes of angina. That was one of the problems, but they showed it was significant, and there was an improvement in 35% of patients compared to 15% in the control group. But also you can see that the improvement of 1 class of angina was almost in 71% of patients. This is the only trial to date now. After this trial in 2015, there is a lot of registries and observational studies that it shows that the successful of the procedure is even better. So it's in most of the studies is 100% because it's not a difficult procedure. You can see also the responder rate, with it's improving. It's about 80% to 85% of responder rates. And also there are new studies with cardiac magnetic resonance to see the reduction of the myocardial burden of ischemia. The last study I want to show is that there is a small study of 200 patients that compared, they took all patients that had reducer, and this is the control group is patients without chronic total occlusions, and the group for intervention, the group for the study was a group with CTO. So they compared the results, and they found that after 6 months, the patients with CTO were more relief than the patients without CTO. So that is encouraging. And here you can see the results that from 100 patients on each group, everybody got the reducer. This is with CTO, without CTO. You can see it's significant. The mean class of reduction of angina was better in the CTO group. They also tried to see the mortality, which was similar. And finally, I want to say that to our patient, this is our patient, we decide to put a reducer. And here are some aspects about the procedure, which is not very complex. The first, you have to take a venous jugular access. It can be right internal jugular vein access or whatever you want, but This is the most direct to the right atrium. Then you can put the multipurpose or AL1 catheter or any catheter you want to measure the pressure first, because if the pressure in the right atrium is high, it has no sense to put the reducer. But if the pressure is under 50 millimeters of mercury, you can place the reducer. And then the coronary engagement, which if you're interventional, you can do whatever you want. We usually use AL1 or multipurpose. The site for, then you do a venography and you decide the site for implantation, which it's recommended 1 or 2 centimeters after the ostium of the coronary sinus, but it is controversial. Many people put it very deep, and some people very in the mouth. Okay. Then the guide catheter exchange can be a problem because this is the knife wrench sheet that you have to put to deliver the reducer, but it's a little bit straight. So when you are changing, you can lose position with the guide wire. So if you put the guide wire, you take out your AL1 catheter and then put the sheet, you can lose position. So sometimes it's better to exchange like this. We usually cut the head of the catheter, the multipurpose or the AL1. We cut the head and put the knife wrench catheter over the other catheter, which is it's an option. And then once you have your sorry. Okay, so for the deployment, once you have your position, the third marker is to put in order with the sheet. So these 2 markers, remember, are for the balloon, and this one is for the sheet. And you choose your position and make sure that this marker is in the sheet, and you can start to inflate, usually 4 to 6 atmospheres. The size of the 2 balloons depends on the atmospheres or pressure you put, usually from 30 to 60 seconds. And we recommend to use a 10 to 20% of oversize of the coronary sinus. Finally, you can do a venography and see the position and to discharge any complications. Here is important just to take out the balloon, because you have a distal balloon. When you take off the balloon, it can get stuck in the stent in the mid part, which was 3 millimeters. So it can bring with the stent. So we recommend to put the sheet inside the knife wrench sheet and make some pressure to take out the balloon. That's the one tip. And for conclusions, reducer is available and safe and feasible intervention for patients with refractory angina beyond CABG or PCI, and of course METs. And reducing the size of the coronary sinus, we have shown that improve the microcirculation, the epicardial coronary flow, the collateral beds, angina, quality of life, and ischemia burden territory. A few things that maybe in the future, I am proposing also we should measure the pressure of after the stent inside the coronary sinus in the future. For example, 3 or 4 months after the implantation, to see if there is a real increase of pressure and to find the connection between the pressure and the good clinical response. Thank you.
Well, Dr. Sanchez, really, thank you very much for your very interesting presentation. I see that our co-panelist, Dr. Cortese, is online, and as he will be the next presenter, maybe if he's the master of the reducer, maybe I think is the most cases in Italy are done by him. So probably we'll say something. Dr. Cortese, you have the word.
Yeah. Thank you, Fari. Can you hear me? Hello? I can see you, but can you hear me?
You.
Okay.
We can
Hello?
hear and can see you.
Oh, great. You can see me as well?
Yes.
Yeah. Hello, everybody.
Hello,
So,
I'm Vladimir Mitor. Thank you for your participation.
It's a pleasure. I'm really sorry not being able to be there, but I'm going to go to a marriage. He's a cousin of mine, so I couldn't escape this situation. You may understand. But really, next year or in the future, I will be more happy to be there. For this year, I am connected. And yes, Fari, you know, at our center, we implant quite a good number of reducers with great symptom improvement. I would say that from our statistics, 80% of our patients have an improvement in their clinical status. You know, these are patients which are very sick, already many times revascularized with cabbage, with stents and DCBs and whatever, and still they have symptoms. With reducer, we may improve the quality of their life. So this is a good alternative to many drugs with many collateral effects.
Okay, thank you for your intervention. Now, by the way, now it's time for your presentation. Drug-coated balloons as valid alternative to metal jacket. Just some words before that. Dr. Cortesi is one of the biggest promoter of the drug-eluting balloons, and I really changed my practice when I went to his center. A man who was doing full metal jacket, now I'm using drug-eluting balloons, even in the case of the myocardial infarction in the old patients. And it's a good idea, by the way, because that you don't have a problem with the blood bleeding, because on this patient, always, very frequently, they have a bleeding. So Dr. Cortese, you have the word, okay, for your presentation. You are here.
Thanks, Fari. I'm so happy that I have created a monster, because yes, you were not a real believer of DCB. Now I have to take the DCBs off the shelf because you are using too many of them. But yeah. So let's see. I will try to convince you that there is an alternative to drug-eluting stents. This is a therapy which is not against drug-eluting stent, but it may be an alternative also for some hybrid therapies. But this is obviously a philosophy which is against the full metal jacket. I don't like the full metal jacket. You can see my slides? Yes. Okay, great. So what is a DCB? Very fast. A DCB is something that is respecting the anatomy of the vessel, without a permanent implantation of scaffold or stent or whatever. And in the future, not talking about 1 or 2 years, but maybe 4, 5, 6, and 7 years, this can be associated when you give the patient a good medical therapy, can be associated with reduced interventions. On the other hand, a drug-eluting stent is something which is very strong. It is a good scaffolding for our vessels, but the vessel is strengthened, because you know that also if we use very thin struts, drug-eluting stents, we create a sort of highways of metal, which may also occlude the side branch, and they may require maintenance, because we know that the curves of the events, even if they are very good, currently available drug-eluting stents, the events are still there. So there will never be a flattening of the curves in terms of target lesion failure with drug-eluting stents. Coming back to drug-coated balloons, we are all aware that current guidelines are claiming that we can use them, and it is a very similar alternative to drug-eluting stent for in-stent restenosis with a class 1 in the ESC guidelines 2014 and then 2018. So for in-stent restenosis, drug-coated balloon is a good alternative to stents. However, let's see if we have other possible uses for this device. I would like to show you a few cases. The first one is a case that we did 1 year ago during the second pandemic of COVID. This was a 70-year-old diabetic woman who had previously a positive nuclear analysis, but nobody cared about this because she couldn't have any cardiologic visit in northern Italy. So no action after this positive anterior nuclear analysis. So she came to our hospital, actually to peripheral hospital for an anterior STEMI in December 2020. But they had many problems in facing this because it was a totally COVID hospital, so the patient was sent to our hospital. She was also on acute pulmonary edema, so she underwent CPAP and she had an active bleeding with a hemoglobin of 5 grams per deciliter. So they also gave her 4 units of blood. Then she came to our cath lab. We had to intubate this woman, and then we managed to see the coronary arteries. This is a highly diffusely diseased and calcific LAD, okay? We don't want to place stents in this patient, with 5 of hemoglobin and an active bleeding, so it was not our opinion. So we gave heparin, cangrelor, and we used scoring balloons 2.5, 3.0 in order to prepare the lesions, and then we decided to use only DCBs for these lesions. And so, well, this is not a stent-like result, but with this calcification, it was the best that we could do for this patient. We used sirolimus and paclitaxel-coated balloon, and that was the result. In the cath lab, she underwent gastroscopy. She had several points of bleedings in her stomach, so we were able to manage after cangular infusion just one single antiplatelet treatment with clopidogrel. And that's it. So we have the data. We have the data showing that DCB is a very good alternative to stents in the frail patients. The rate of MACE and also stent thrombosis is much lower with DCB. Now, I don't want to lose too much time on this setting because I think that DCBs can be used also for a normal patient with native vessel disease. On the other hand, we have drug-eluting stents. Are really good. These are the events with Science and Resolute, Onyx. They are quite the same. The events are down, they are low. So we have very good devices in our shelves. However, if we go on, we analyze the patients that have been enrolled into this study, but also in our study, it is quite the same. We can see that the lesion length is very low, 13 millimeters. Okay, so this is something that we don't treat in our patients. It is very rare that we use such small stents, at least in Italy. On the other hand, we can see, I was mentioning this before, that with the drug-eluting stent, also if Science or Onyx are very good, there is still an increase in the events year by year, 0.8, 1% of events of target vessel failure. And then we have to understand one thing, that when we implant a drug-eluting stent, we implant a permanent scaffold, but we also implant a temporary drug-eluting stent, because all available drug-eluting stents do elute the drug for 3 to 9 months. Then it is metal. And we can see here clearly by this study by Salvatore that the outcome after the first years, it is quite the same as for bare metal stents. Metal beyond 1 year is metal. So this should be very clearly stated in our head. Another point, I was mentioning before that we don't treat patients with 13 millimeters lesions because our patients have diffused railways of calcific atherosclerotic lesions. So currently, we treat these patients only with metal, and this is not correct in my opinion, because if we go and check the outcome of the same drug-eluting stents in a more complex lesion setting, the outcome is much worse. You can see here that the rate of target lesion failure, it is double in small vessel disease when currently available drug-eluting stents are used. And then again, against drug-eluting stent, if we implant long stents, the risk of target lesion failure is almost double, and the risk of stent thrombosis is more than double than when we treat patients with the same device in shorter lesions. And again, if we treat left mains, like the 10-year outcome of this very famous Nordic bifurcation study, there is increase in mortality when we use more stents and we use complex stenting at bifurcation of the left main. And finally, we also have the bleeding risk. This study, which was recently published 1 or 2 months ago in JACC, clearly shows that there is an increased risk of 42% of intracranial hemorrhage when we give our patients DAPT instead of aspirin alone. So we have to keep all of this in mind when we treat our patients. We have an alternative. Yes, we do have it. We have drug-coated balloons. I'm going to show you a few cases. This is a CTO, quite easy CTO, I would say, that was treated after lesion preparation with a paclitaxel-coated balloon, 2.5 by 40 at high pressure. This was the final result, which was pretty good. And then we checked again this patient after 6 months, and this was the result. Okay, so we can see that not only the healing of the lesion, but also the increase in the lumen of the patient. We also did the OCT in this patient, showing the total healing of the lesion. Do we have scientific data? Yes, we have scientific data. This study clearly shows that if we leave a dissection, if it's not a flow limiting dissection after DCB, the risk of thrombotic occlusion is very low. And in the vast majority of the cases, the dissection do heal at control angiography after 6 months. And again, if we are using a good paclitaxel-coated balloon, the rate of lumen enlargement is very high, occurring in 2/3 of the patients during the same angiographic follow-up. We also have larger studies with clinical follow-up, like the basket small 2. This study is a randomized clinical trial in native vessel disease between 2 and 3 millimeters, treated with paclitaxel-coated balloon versus drug-eluting stent. And the outcome is there. After 1 year, no significant difference in terms of MACE between drug-eluting and paclitaxel-coated balloon. Quite the same after 3 years. No differences in terms of MACE between DCB and drug-eluting stent in native vessel disease. And what about the future and the present? The present is here. We have Piccoletto 2 study, which was recently published 1 year ago. This was a study showing the performance of a novel generation paclitaxel-coated balloon versus science in native vessel disease. We have the primary endpoint and the 1 year follow-up. Primary endpoint was late lumen loss. And here we hypothesize no differences between drug-eluting stent and DCB, but the DCB did perform better than drug-eluting stent. We had a late lumen loss in a small vessel disease of 0.04 versus 0.17. So we also obtained the superiority of this novel technology versus science. And let me show you a few more cases. This is a CTO of a patient with a calcific lesion, which was managed by a paclitaxel-coated balloon. And this was the final result, which was very good, sort of stent-like in this case. And also the flow was very good with a QFR of 0.99. So when we face complex lesions, we have to think at how we would manage the patient and not to give futility to our eyes for the immediate result. We have to think in advance to the future of the patient. We also have sirolimus-coated balloons available in our shelves. This is the ISMO registry. We are collecting the primary endpoint 1 year data. The primary endpoint of this study is target lesion revascularization. I am so happy to tell you that in the next 2 months, we will analyze the primary endpoint in this, which is the largest study ever done in terms of drug-coated balloons for native and in-stent restenotic lesions. We have the preliminary data for the interim analysis in a subgroup of patients, which is showing very good MACE rate of 5.8% at 1 year and TLR of 2.5 and no safety issues. And then we also have a comparison between paclitaxel and sirolimus-coated balloons. This is an investigator-initiated study which is showing the clinical follow-up between Elutax, paclitaxel, and Magic Touch sirolimus-coated balloons at 1 year. In terms of MACE rate, we enrolled 1,140 patients, and after propensity scoring matching 290 patients per group. And what we saw was that there was no differences in terms of MACE and any determinant of MACE between paclitaxel and sirolimus-coated balloons. This is another CTO which was pre-dilated. Then we use a sirolimus-coated balloon for a distal part. This device has a very good deliverability. Sirolimus-coated balloon again here. And this is the final result. We had to put a stent in the middle part of the lesion. So this is opening another possibility for our complex patients. If we predilate the lesion, if we have a focal dissection, we use DCBs for the entire length of the lesion, and we put a stent just to fix the focal lesion. So drug-coated balloon, and drug-eluting stent in this part. So which is the future? The future is already here. We are ready to start enrollment in this study. This is a transform study, and this is the panel of the steering committee that I am coordinating. I'm really happy to. This study is a study which will enroll patients for the next 18 months and will follow up them for 5 years. We will include all patients with native vessel disease between 2.0 and 3.0 millimeters, and with lesion length, this is a step forward up to 40 millimeters. And we will randomize these patients between Magic Touch, sirolimus-coated balloon, and Xience. In case of flow-limiting dissection after DCB, we may decide to put spot stenting there, but not to do full metal jacket. And we also have another study which is going to start enrollment. This is the Piccoletto 3, which will enroll only patients with very complex lesions, meaning CTOs and more than 40 millimeters lesion length. And in this study, which is international multicenter randomized, we will compare sirolimus-coated balloon to paclitaxel-coated balloon to thin struts drug-eluting stents. We are working a lot on this topic, and we participate and we organize congresses on DCBs. We also do hands-on courses like the DEB School, which arrived recently at the 11th edition. We do webinars, and we are also working in order to have some simulators. So if you are interested into this technology, please contact us, Dr. Fuladband or Dr. Eric, and we will keep in touch. So my conclusions are that DCBs are a valuable alternative to drug-eluting stent in many, not all of them, but many native vessel disease anatomical settings, either using them alone or as a hybrid treatment with drug-eluting stents. Please remind that DCBs are not created equal, and you should rely only on your experience and only on drug-coated balloons, which will have good platforms and studies which are showing a robust clinical program. The new frontier will need to be patient focalized, mostly in the sicker patients and not device focalized. So this is why we're working a lot on hybrid treatment. And I thank you for your attention.
Well, Dr. Cortese, thank you very much for your very interesting presentations. Are there some questions or discussions or remarks from the audience? If not, sorry. No, I saw you, so you have to. No, you have to say something. I saw you.
One question, please. Dr. Cortese, thank you again. Your choice from using drug-eluting balloons is dependent from diameter of artery or not?
Well, yes, we don't have the chance of using intravascular imaging, so we use our experience by the visual estimation of the vessel size. Usually, the ratio between the DCB and the vessel size should range between 0.8 and 1:1 to the vessel size. What does it mean? It means that we need to prepare the lesion. Then we assess the result. If the result is really good, we go for a 1:1 dilatation with a drug-coated balloon. Otherwise, if the result is not so good and we don't want to risk to incur into dissections, flow-limiting dissection, we go a little bit slower in terms of diameter, so 0.8, 0.9 to the vessel size.
Well, let's say when the data speaks, the gods keep silence. You know, with this data, robust data about the results of using drug-eluting balloons and their comparativeness with the result with the stents. But I think that in some situations, really, is very important the using of drug-eluting balloons. Like, for example, in CTO, when you reopen the artery, you have a flow, and you know, very often the CTO artery is a spastic if you're not using IVUS or IVUS to decide the diameter to stent. I think the using of the drug-eluting balloon, as in some cases presented by you, it's a very good option, because after that, when you check the patient, you see the real diameter, and if the result is okay, you saved a stent to this patient, the metal to this patient. So generally, I can say that the using of the drug-eluting balloons, if I'm not correct, if I'm not correct, you can intervene. But I think it's a philosophy. This is the philosophy to use the drug-eluting balloon, and you have to change your mind. No, this is really philosophy. Like people who are doing the peripheral arteries. Yesterday we performed with the Oki peripheral angioplasty on the in your hospital for the first time. Yeah, the peripheral artery, the femoral artery. 100% you have to avoid stents. The result maybe is not 100% good, but if you have a flow, if you have not a bad dissection, leave it, because stents in the femoral artery, there will be very high percent of restenosis, and this is the philosophy that Cortese is trying to transmit. The philosophy to, if you have a result, use a drug-eluting balloon. Don't afraid to use drug-eluting balloon. Don't fix yourself with a stent. Not you, I'm talking to everybody.
One question more, Dr. Cortez. Philosophy of using a drug-eluting balloon can be changed concept like absorb stents before?
Well, yes, you know that that is another story, which in my hope will be said again, because we invested a lot also at our center in Absorb in terms of studies and study proposals, but that was a failure. We have to admit this. The DCB is going slowly. You know that how the things are working. There at that time of Absorb, there was a single company which maybe too much pushed on this technology, and the technology was not ready to be for the patients with complex lesions, and so the terms of stent thrombosis scaffold thrombosis was really high. For DCB, it will be different, because we may admit that in some cases we have failure of DCB. Obviously, we have failure of DCBs, but there is never a risk of safety with DCB. We don't have the risk of thrombosis. If we do, as it should be done, an assessment after 5 minutes from the inflation, and we see that there are no flow limit in the session, the risk of thrombosis is very similar to zero. So what can happen? It can happen a restenosis, a reocclusion of the vessel. Yes, this can happen, but no risk of thrombosis.
Thank you.
I see that Dr. Maksudov has a question to you. Please, Dr. Maksudov.
Are you listening? Dr. Cortez, what about using TEPS in acute coronary syndrome? To be precise, in STEMI, do you use drug-eluting balloons? And for example, do you leave your case only on drug-eluting balloons, not to put a stent in the occluded artery? What are your experience about that?
You're talking about acute occlusion of STEMI, I mean, or any ACS?
For any ACS.
Yeah, well, the cases that I've shown before, the first one was in an acute setting, obviously. So we use it. It's not a matter of the clinical presentation of the patient, but only on the lesion characteristics. If we have a high amount of thrombus, obviously we fear the thrombus and the risk of distal embolization. But if we prepare correctly the lesion, in this case, for example, with thrombus aspiration, and we remove great part of the thrombus, so we may use drug-coated balloons, and it is quite the same for as for native vessel disease in stable patients. We also have studies. There is the PEPCA, the non-STEMI study, which is showing the equivalence in terms of clinical outcome between drug-eluting stent and DCBs in this setting.
Bernardo, I would like to inform you about first successful case in peripheral artery in our cath lab. This case performed Dr. Fari and Dr. Octay. Yes. But thank you for support and help. This is very important for us.
Well, Fari is a very experienced peripheral guy, so I'm sure that the case had success. I'm so happy that you started doing peripheral cases, really.
Okay, Dr. Cortese, thank you very much for your participation. Really, thank you very much. And now we continue with the next presenter that we change a little bit the order, so probably it's me. Okay, so I'm going to talk about the renal insufficiency. Okay. Maybe you have to present.
Now, Dr. Fari and kidney problem after procedures and using of contrast.
The problem with this contrast-induced nephropathy is really very important. So this is our hospital, and if you look at the right literature, this is the diagram, the photo from some years ago, I think 4 or 5 years ago. The amount of the articles, amount of the studies are so much that when you look at these things, you can feel yourself like I feel myself some years ago in the metro of the Tokyo, everything written in the Japanese, and at the end you didn't know what is the correct approach toward the patient that when you're going to use the contrast. So the contrast nephropathy is the third case, as you know, of acute kidney injury in the hospitalization, during the hospitalization, and definitely has an unfavorable impact of patient outcome as associated even with the short but also with the long-term outcome regarding infarction, myocardial hospital, cost of the stay in the hospital, and in, let's say, in most we're going to the definition, I'm sorry. The definition, well, we know that this is the increasement of the creatinine level with 0.5 milligrams per deciliter from the baseline, or 25% from the baseline, depends on the definition. But there are some other definitions because that strictly regard whether the kidney injury, the renal insufficiency is due to, it could be definitely associated with the contrast or not. But I think for the practical reasons, the first definition, increasement of the creatinine, is sufficient for us with 0.5 milligrams or 25% from the baseline. So we know that the incidence is not so much, 2-3% of the populations, but this rate increase quite much with the risk factors, especially with the multiple risk factors, could arrive even to 70% in the patient with the chronic renal insufficiency, pre-existent, age, anemia, chronic heart failure, hypotensions. And there are some other risk factors that they're important, but they don't enter in the risk scores, except in one of them, which is the 70 parameters. So generally, the CHIN, or contrast-induced nephropathy, has a good outcome generally, mostly in the patients. And after some periods, the values return to the baseline. But in the patient with pre-existing renal insufficiency, there is a real risk to continue and to damage the renal function, even to arrive at the level of the dialysis. So if you look at this large studies with 1,000 patients, those who developed renal insufficiency after contrast in the hospital, they had a really increased outcome regarding the higher rate of strokes in the hospital, higher rate of bleeding, cardiogenic shock. Whatever you look, this is significantly higher in those patients who developed. I'm not saying that every patient will develop, no. but the risk of the development is higher. So the pathogenesis, I didn't understand the pathogenesis. I mean, I read all these things. There are a lot of theories of osmotic, endothelial, hyperviscosity, cytotoxic effect. Probably the cytotoxic effect and osmotic effect are one of the most important because the hydration reduces the risk of chin clearly. So probably this is one of the most important reasons. But if you see, all of them can contribute to the development of the nephral contrast-induced nephropathy. So there are risk factors, as we said, connected with the patient. There are risk factors connected with the procedure. For example, the type of the contrast. Obviously, these days we are using good contrast, so this is not so important, but the dose of the contrast is very, very important. And well, the way of submission of the contrast, venous or arterial, also plays a role, but we are doing mostly the arterial, so it's a little bit higher risk. And also whether the procedure is elective or urgent, because in the elective, obviously elective procedure, you have a time to prepare the patient. In the urgent procedure, you don't have the time, so the risk, and also you don't know what is in front, you're in a hurry, sometimes during the night, so probably the amount of the contrast is higher, and especially if the patient is not prepared. And then also it's very important that not to repeat the procedure before 48 or 72 hours. You have to give time to the rings, to kidneys to repair their function. And some therapies, fans and antibiotics and so on. So as I said, the risk factors, one of the most important risk factors is the pre-existing renal insufficiency. And the patient with pre-existing insufficiency, renal insufficiency and diabetes, we can arrive up to 50% increasement of the renal insufficiency. So the guideline says, before putting a patient on the table, to perform the risk assessment, whether this patient is at risk or not to develop kidney injury after contrast. And there are high-risk patients, medical risk conditions, and risk scores, many risk scores. I think that one of the best one is Mehran score, even that in the Mehran score, there's a amount of the contrast is included, but you can calculate the amount of the contrast that you are going to use according to your eGFR. So when you have a patient, you calculate hypotension, the need of the balloon, heart failure, age, anemia, diabetes, and there are points, and according to the sum of these points, you stabilize the risk. But about the contrast, you say, okay, this patient has the eGFR of 60, so I can use about, I'm permitted to use about 120 contrast. You put 120 contrast and you have 1 point for the, because every 100 milliliters of the contrast gives you 1 point in the Mehran score. The other scores, GERM is a very interesting score, but you need a special site and app to use it to receive the data. So the second type of the clinical estimation of the risk is according to the eGFR. And if you have a eGFR above 60, obviously the patient is not at risk. And even the study are saying we don't need to do anything to this patient, even there's no need to do hydration. Then if you have a 30-60 milliliters of eGFR, then the patient is too low to moderate risk, and then below 30 is severe, which means high, or below 15, very, very high risk. So this is also the risk stratification. So the preventive nephrotoxic drugs, to suspend them, which means not suspend them, because the study is saying ACE inhibitors and sartanics, generally the study now, the approach is, if you have a patient in these drugs, don't touch it, don't modify the doses. But if your patient is not taking and you want to give these drugs, it's better not to give before the procedure, to expect the end of the procedure. Biguanidine, especially the metformin, is not exactly the nephrotoxic, but it's a lactic acid, so should be suspended before the procedure. We suspended 24 hours before that, but studies are saying even 48 hours. So chemotherapeutics, 7 days before that, but we don't have patients with them. So diuretics, also here, the study is saying, look how is the patient. If the patient is, if you use the impedance BIVA system, you can decide whether to use diuretics or not according to the total fluid volume of the patient. But our approach is the diuretics to to see the amount of the diuresis via hour or 3 hours diuresis to decide whether to use diuretics or not. FANS or non-steroid drugs generally have to be suspended attention with the patient with the recent drug-eluting stent. About the acetylcysteine, you know, there are a lot of studies, there are the different theories about the beneficial effect of this drug. The first drug, the Teppel was the first one who said that this is a good idea to use it. The very big study, ACT study, on a very large number of patients, they find no difference about the acetylcysteine using in the patient as a prevention. Many other studies are saying, yeah, maybe it's okay to use it, or that at least the meta-analysis says there is some benefit. We are using 120 milligrams twice a day before, the day and after the procedure to those patients, because at least doesn't harm the patient. This is at least a drug that doesn't harm the patients. About the statins is the same thing. You know, there are some studies are saying the statins are protective effects, in mostly rosuvastatin and atorvastatin. So in our and if you look at these studies, meta-analysis are saying maybe it's better to use, as we don't know what to do, and we don't know what to do, we are doing statins in our patient immediately. If the results are better if your patient is a naive patient, it doesn't take any statins. If he's taking, if he doesn't take anything, we give rosuvastatin 40 or atorvastatin 80. If he's taking some statins, we change it to atorvastatin and rosuvastatin. So this is our approach. And then hydration is the most important thing, working on the different mechanism. One is the reducing the osmoticity of the contrast, increasing the flow to the kidneys, and reducing the concentration of the contrast medium, so reducing the direct toxic effect. The first studies were from Maioli in a STEMI patient. In those studies, we know that there is a benefit of using hydration, and I will show you some studies that saying even that there is no need to use hydration. So forced diuresis, this is a very old study. I'm not saying that you have to do that, but in this study they give dopamine to increase the diuresis, and with the diuretics they increase the diuresis of this patient. They found it that in this patient you have a less incidence of the nephropathy. But after that, now I'm not saying use dopamine, but now we use forced diuresis with using the renal guard, which is a very intelligent system that measures the amount of the diuresis of the patient and increase the volume of the infusion according to the diuresis of this patient. So if you need to achieve a higher diuresis, you can even do the diuretics, and the infusion rate is according to the amount of the diuresis of the patient. And this is our studies that demonstrating in the control group and the patient with the forced diuretics therapy diuresis, we have a better result, significantly better result, sorry, in reducing the chin. So again, another study demonstrating the benefit effect. Natrium bicarbonate 1.4% is another of the drugs that some studies demonstrate beneficial effect. But let's say the most beneficial effect of the natrium bicarbonate is in the emergency situation, when you don't have time to for example, in this situation, to hydrate the patient. Again, about the bicarbonate, there are different studies, but again, meta-analysis, let's say, goes toward the benefit in emergency situations. So in our practice, patient who is with a STEMI, we don't have a time to prepare him with 3 or 4 hours, for example, unstable angina, time to call the specialist. Generally, we start with bicarbonate. And the dialysis, I just mentioned it, is one option that is not average in the in our practice, except in the patient with a very severe renal insufficiency. Then you contact the nephrologist, and you put yourself in the contact with the nephrologist to decide whether to use dialysis after the coronary angiography and angioplasty. Anyway, some studies demonstrate beneficial effect of the dialysis. Remote ischemic preconditioning is another technique, which is, in the infarct, we did some studies some ago to using the inflation of the cuff on the upper arm for 5 minutes, 5 times, and the releasing of this vasoactive substances, they have a vasodilatative effect. For example, in the infarct, you can reduce some studies demonstrate yes, some studies not, but can reduce the amount of the no reflow phenomenon. But in the kidneys, you have the vasodilatation. So probably also there in a small study demonstration is that you have the reduced incidence of the nephropathy of contrast from contrast by using this technique. It's difficult to say. BIVA is another, this is a bioimpedance vector analysis. It's a small machine. I don't know whether you are familiar with this, a small machine that measures a little bit of charlatan history, but anyway, we have it, and there are values, demonstrating values that you measure the impedance and you calculate the total volume of the fluids in the body of the patient, and there are some cutoffs, and if this cutoff is above 380 ohms for the men and above 320 for the females, it means that your patient is deshydrated, so you can increase the amount of the hydration safely. So this study demonstrates that the patient that had a higher level of the impedance resistance height ratio or vector height ratio above the 350, they were in a low fluid level, so they had a higher level of the incidence of the renal insufficiency. So this is the same analysis of this. Okay. So another this is some kicker, as I say in Italian. One very interesting study published not in a small journal. This is a study published in Lancet around some years ago. Control group, no hydration. All patients with moderate to severely impaired reduced renal function, kidney function, and the other group with hydration. The results were no difference in according for the nephropathy. Even in the group with hydration, they had a higher incidence of heart failure or heart failure because of the fluid overload. So the situation really is very difficult to say. So, but the most important thing is the amount of the contrast. Now, this is the only, because renal insufficiency is from the contrast. So if you can reduce the contrast, probably you will have a better result and a lower incidence of the nephropathy. So the guidelines recommended the amount of contrast to be to reduce as much as possible the amount of the contrast, and not the assist system, automatic systems that we use to inject the contrast, they reduce the amount of the contrast, but we are using this device, which is the divert system. When you do a coronary angiography or angioplasty, when you inject the contrast, very often you have the contrast around the coronary sinus, because the pressure of the artery is higher than the pressure of the amount you injected in the catheter, and you lose the contrast in the aorta, which is not necessary. So the system calculates the pressures and aspirates that amount, regulates the pressures and aspirate the amount of the contrast that is in excess. So in generally, we can save about 30 to 40% of the contrast during the procedures. And the studies demonstrate obviously that reducing of the contrast is better with the divert. In Florencia, they did some studies on the system. Is very expensive, 500 euros, and it's very difficult to obtain. To use it, you have to take the permission from the director of the hospital. It's a little bit difficult situation, but anyway, we have it in some patients that are at risk of the renal insufficiency. So going further, we had protocol in our hospital, let's say not computer-based, it's Excel-based, but done by us. So sometimes the doctors, when they fill the protocol, they cancel or copy paste and they damage the protocol, but the protocol is relatively good working. You have the first part, which is the anatomic, the anographic data, and then this part here, this part here is a message. This is a message for the doctor, whether the patient is at high risk or not, the level of the risk, amount of the contrast, or whether to use the divert system. So if you go further, this is the second part that you have to fill, and it's not very difficult. I mean, you fill here the ejection fraction, pressure, these vitals, and then some laboratory data, then some risk factors. But some of the risk factors automatically will be changed if you put a low pressure. For example, the patient will go to hypotension. Now here is hypotension because there is no value here. I will show later. So this is the Mehran score. The Mehran score goes here to calculate the level of the risk of this patient. EGFR is calculated here according to the creatinine level, and you can see after that, after the filling of the fall, this sheet, the level of the risk according to the EGFR. And then these are the messages. If you put here, for example, the patient is not taking ACE inhibitors, sent to the measure, the doctor says the message is not to introduce this drug. So if you go further, for example, yes. So and then it's the third part, the amount of liquids that you can inform to the patient according to the data you entered in the program. So now there's nothing because we didn't put any data. But if you go further, for example, in this patient, for example, we put the name, we put the data, his birth date, and the diagnosis. Well, I didn't put the diagnosis, but anyway, the ECG there is. And here is the important part: is elective or non-elective patient. You can choose this. Everything is with the following menu. So then we put the other data. The ejection fraction, it's a normal patient. You say normal patient with normal creatinine, with everything is in range. So we go here, you cannot see maybe the color, but goes to this level, the low EGF risk and the low EGF score. And if you go further, the message to the doctor immediately is that this is a low risk patient. You can use 160 ml of the contrast, and there is no need to use divert, and the amount of the liquids. Oh, so sorry, mamma mia, porca puttana. One back, sorry. One back. Could put my presentation. Okay. One back. One back. So this patient is there is no need to do the divert, and the amount of the liquids according to his EGFR is 70 milliliters. I mean 1 ml per kilo per hour. But the doctor here have to say yes or no, and he can say no. I'm a doctor. I want to put 100, and you have to write there the amount of the liquids to the patient, so the nurses will do this amount, and then there is a diuresis, and to insert the amount of the diuresis and the automatic calculation of the liquids inside of the patient, and then the balance of the patient to decide whether to use diuretics or not. And if you go, for example, at this patient, the same patient that we said, but for example, we put a low ejection fraction, 70 pressure, systolic pressure, 80 is wrong, no? 70 systolic pressure, 200 glycemia, creatinine, but creatinine level is 1, and hemoglobin is 7. So the system says to you, for example, that it's not bad to evaluate one hemotransfusion. And according to the EGFR, this patient is at low risk, 60, 80 EGFR, so it's a low risk. And according to the EGFR, we can use 160 contrast. But according to the Mehran score, is a very high risk. So the amount of the contrast that we can use according to the calculation of the EGFR, 0.7 multiplied 57 ml of the contrast. And the message to the doctor will be that this patient, because the system takes the higher risk, not only EGFR or Mehran, between those two, the systems choose the higher risk, which is very high risk for developing the nephropathy. Amount of the contrast is 57, and at 57, it's not so much. The system says to you, it's advisable to use divert system. And the amount of the contrast, the liquid that you can infuse in the patient is 140 according to the system. But the doctor says, no, I am afraid I am going to put 100. My diploma is from the University of Pavia, for example. So I want to do 100 of ml. Or for example, a different patient, STEMI patient, where we have the immediate angiography with this data that you have here, the risk score, for example, because he has only the creatinine level is 3, everything else is almost okay. So we go to the high risk according to the creatinine level and mid risk according to the Mehran score. And for example, when you fill the data, you put he's taking ACE inhibitors, he's taking diuretics, he's taking fans, he's taking metformin, and immediately the system says to you, yo, stop it, do that, call, for example, the consulenza, valutare eventuale consulenza, eventually take in consideration one nephrology consultation because of your creatinine level. And the last thing is that the system says to you, this is at high risk. The amount of the contrast is 30 ml. 30 ml, you can do anything with 30 ml, you know? So I said, do divert. It's a very, very, very important to use divert. The system says, and here gives the possibility to the doctor to decide whether to use bicarbonate or physiologic. And in this case, for example, the amount of the bicarbonates are 2 ml per kilo per 1 hour, and then 1 ml per kilo per 3 hours, so 140 milliliters of natrium bicarbonate in the first hour, or 70 and 70 for the second hour. And the doctors, or physiologic saline infusion, but the doctor says, no, I will do 0 physiologic infusion because it's an emergency patient. I will start with 140 ml of the bicarbonate, and then we'll decide further what to do. So this is the interesting system, and we are trying to develop it better. I think that at this point I can say thank you very much for your attention. It was a little bit long lecture. Thank you.
Thank you, Fari. Any question? Very interesting scoring system for this group of patients from everyday clinical practice. Your opinion about drugs in SIN, in this group of patients, any drugs is working or not?
You mean for the prevention?
No, after clinical manifestation, kidney disease, after procedures.
Well, as I said, the patient, like therapy, practically the only therapy when developing renal insufficiency is to continue with the aggressive hydratations and aggressive increase of the diuresis without putting the patient in the dehydration, because the creatinine level will increase again. So the only thing that we do in this patient is that. But I will we continue with acetylcysteine, not for 24 hours, but still the patient is in the hospital in these patient groups. And but it's very important, the consultation with the nephrologist. Generally, they are very, very restrictive to any measures that, for example, dialysis, they never, except if you have a 10 creatinine, then they say, okay, let's do hemodialysis. But the drugs, no, there's nothing.
Usually early dialysis, changing prognosis this patient.
Well, it depends. In sense, depends. I mean, if your patient is really with a high level of creatinine, for example, 3.5, 4, and you did the coronary angiography some times ago, and you know that you will have a very long procedure with a long amount of the contrast, it's advisable to perform preventive hemodialysis. But our nephrologists, they are not doing that. They are not doing that. Even after the contrast, Well, we try to stay with the low contrast. If we go to 150, for example, the procedure sometimes is like that, 150, we call the nephrologist and we say, look, he has a 3.5 and the contrast is inside of his body. So let's do immediately hemodialysis. Then depends how you can sell yourself. Okay, this is unfortunately with the nephrologist is like that, unfortunately.
Thank you.
So you can present the next, I think it's Oktay maybe, or I'm wrong.
Yes, next is Dr. Oktay Maksudov and original approach, distal palmar approach.
Just to say that Oktay is the one
In Oktay way.
everywhere. Puncture, he will do it. Even behind the ears. Okay, Dr. Oktay.
First of all, I want to thank to Dr. Mitov and his whole crew for inviting us every year for ZASync. So we're like at home here. Thank you very much. So I'm going to show you one left main case, and that was done by me and Dr. Fari in a novel approach. So it's a case about 77-year-old lady, retired. She was represented at our hospital as an unstable angina. She was symptomatic for a few days at the date of admission. From her history of illness, she was hypertensive. She had hypertension. She has positive family anamnesis of coronary artery disease. Due to posterior inferior STEMI, she got 2 deaths in circumflex artery in November 2018, and 1 month later, a long tapered disc was implanted in mid part of the LAD. She was diabetic, highly obese patient. From non-invasive methods, there was only negative T waves in anterolateral leads. Laboratory was absolutely without any reference values, and from echo she got diffuse hypokinesia and dilatation of the left ventricle. So this is her angio. In the right coronary system, there is significant stenosis in the mid part of the RCA, and also significant stenosis in mid part of the PL branch. In the left coronary system, there is a distal significant left main stenosis involving the ostium of the LAD. By Medina classification, it's 110, and the stents in LAD are okay, but there is also a significant in-stent restenosis in the circumflex artery. I must mention that this diagnostic angio was done by transulnar access due to radial occlusion of radial artery due to previous interventions that were done by the right radial axis. So this is another projection of the LAD. Cardio team was consulted, and the recommendation of the cardio team was bypass surgery, but the patient categorically refused it, and she was only for the percutaneous treatment. So in this case, which is better, the provisional stenting or 2-stent strategy? Not always one stent is better, as courtesy of Terry Lefebvre says that approximately around 50% of the cases is done by 2-stent strategy. So when to do a 2-stent strategy? Of course, when the side branch is bigger than 2.5 millimeters, then when there is a long plaque in the side branch, when there is a severe dissection due to predilatation, and of course the geometry for rewiring of the side branch. If there is a cut side branch angle, when it's near 90 degrees, you should do T-stent strategy or its step or some modifications of the T-stenting. And if it's not, you should go for some of these strategies: mini crash, culotte, V-stent. So what we have done and what is our strategy? Of course, We did some measurements. The main branch and side branch were approximately the same size, and the angle between them was around 78 degrees, so an acute angle. The QCA said that there is a significant stenosis in the distal left main involving dostum of the LAD, around 67%, and of course significant instant restenosis on around 86% into the circumflex artery. So guiding by the rules, this was a big side branch vessel with unfavorable geometry for rewiring. So the sizes of the main and the side branch were approximately the same. So we go for the culotte stent, culotte technique stenting. Everybody is familiar about the steps. I'm not going to mention them. And what is specific about this case is that it was done by distal ulnar palmar approach. As you know, that the palmar branch is a superficial palmar branch of the ulnar artery. We had some study about distal ulnar palmar approach. This is our experience. These are the numbers collected by 1 year from October 2019 up to October 2020. 58 patients, from which 22 were only coronarographies, 32 were percutaneous coronary interventions, and two of them were rep PCIs. That means that the first and the second intervention were done by the same right transulnar axis. The approximately age of the patients were 61 years. And you can see that we have used all kind of introducers, and we have done the follow-up on the 24 hours after the intervention on the first, third, and the 6 months. So the ulnar artery at every single of those 58 patients were absolutely patent. What is common for the patients is that they were highly obese with a body mass index average of 31. And what is the experience in the worldwide rank? There are 2 studies, internal studies done for the distal ulnar axis. The one is smaller, is smaller with 15 patients, and the other one is the biggest. Is done in Iran, that's involving 235 patients. What about the technique, material, and the methods? Technically, we give midazolam to all the patients 1 milligram before the procedure. Midazolam was not given to the STEMI patients because of the highly spastic palmar artery, and the palmar arm was positioned in 45 degrees to avoid the hyperextension and artery stretching and collapsing. You can see the puncture spot. It's the puncture sites it's around 1 centimeter approximately distal and lateral to the pisiform bone, and about 1 inch distal to the wrist crease. After puncturing, which is done by the traditional needle, you go with the wire. If the wire that is commonly used for introducing the sheet doesn't pass, you should go for a checkup with the angio. If the wire doesn't pass, you go with the coronary classic wire. After that, we gave a spasmolytic cocktail containing verapamil and heparin, and every single of those patients were performed scytogram to verify the arterial anatomy. After the procedure, the bandage is the compressive bandage is what we use, and the hemostasis is with duration around 3 hours, and every single patient goes with the saturation of the small finger, the last finger, and every single one of them had the saturation above 95%. This is the exclusion criteria which the literature says. We didn't have not even single one of them. So this is the puncturing and how the blood flows goes. This is how the needle goes. It's very easily, smoothly. And this is the puncturing of the patient. We go first with the four French introducer, and after that we change it with sheetless guiding catheter, 7.5 Asahi. This is the sheetogram as I mentioned. You can see that the radial artery was occluded. So in this patient, we use sheetless guiding catheter, EBU, 7.5 French, and immediately we put two workhorse wires towards LAD and circumflex artery. We did pre-intervention IVUS. What IVUS showed us is that there's a significant distal left main stenosis around 60% with an area of left main of 5 square millimeters. So we did kissing balloon. We started the procedure with 2 kissing balloon. After that, we did predilatation of the instant restenosis of the circumflex artery with bigger balloon. This is the result after the predilatations. Then we put the stent in the circ, and this is the result after the stenting. Of course, as the clot technique goes, rewiring of LAD, opening the struts with smaller balloon, and deploying the stent from left main towards LAD. This is the result after stenting. Then we did POT with NC balloon 4.0. This is the result after POT. Rewiring of the circ, post dilatation, second kiss, and of course final POT with 4/15 NC, and this is the final result. Good angiographic result, which was confirmed by final IVUS. And what shows the final IVUS? This is the IVUS in LAD with area of 11 square millimeters and maximal diameter of the stent 4.1 millimeters. Good expansion of the stent. Also in the circ, the same results, area above 9 square millimeters and maximal diameter of 3.7 millimeters. And in the left main, you can appreciate the numbers, area above 12 square millimeters and the maximum diameter of 4.2. This is the stent boost picture, and of course the final result. Good angiographic result with Dimitri flow towards LAD and circ, and in spider projection the same. What about the puncture spot? This is the introducer after the procedure, the bandage, the suturation, and 3 hours after removing the bandage, the hand is in perfect condition. So the hand was okay. So what are our conclusions from this case? That the transradial and transulnar approaches are associated with fewer bleeding and vascular complications than the transfemoral access. And the distal ulnar palmar approach, either for the diagnostic angiography or the intervention, is safe, feasible, and reliable. With the price of more difficult puncture and risk of access failure, there are some advantages as lower risk of upstream arterial occlusion and shorter hemostasis. In case of complex coronary anatomy indicated for cardiosurgery, if the patient refuses it, and if it's possible to do a PCI, it's an adequate solution. So every time complex bifurcation remains a challenge for the PCI, and in such situations, IVUS guidance is preferred. If you had it, that you should use it. Provisional sentings is the preferred solution, and technique of left main stenting is preferable choice of the operator, but also depending of the anatomy, and the final result depends on the experience of the operator and of course of the nurse who is our assistant. And also, as the last conclusion, as Albert Einstein said, make everything as simple as possible, but not simpler. So thank you very much for your attention.
Well, Dr. Oktay, thank you very much for your interesting presentation, very interesting approach. If there are no questions from the audience, as we are a little bit with the time, we have a lack of time, we go directly to the next presenter, which is Dr. Rzeszowski, who is online and will present another interesting approach, retrogradely approach in the peripheral arteries. So please, Dr. Rzeszowski, to be connected.
Hi everyone, but I need to be co-host to be able to share the screen. Can you hear me? I cannot.
We cannot hear him now.
Okay. I can share the screen now.
Okay, now we are hearing you, Sashko. Welcome to our symposium and the Congress. And,
hi everyone.
Okay.
Hi everyone. First of all, I want to congratulate Vlado for the first peripheral case in Zaječar. I wish you a lot of cases in the future. Can you see the presentation?
Full screen.
Okay, it's full screen. Can you see it?
Not yet. You're not on a full screen. On your computer is a full screen?
Yes, on my
below. Slideshow, yes, slideshow. Slideshow, I think is at the lower line somewhere there.
Yes, I know it, but
okay. Next.
Can you see it now?
Yes.
On my computer is full screen.
Close and open again. This is a suggestion from the technician here to close and reopen your presentation.
Okay, I will stop share and I will start again. Okay, share. Can you see something?
Okay, now go to the slideshow.
Okay, it's good.
Unfortunately, no. Maybe the technician can say something.
Probably you have problem with processor, but you continue in this form.
Yeah, we'll try again.
Okay, try yes. Try. Anyway, for us, it's interesting.
Okay.
So?
I'm trying to, okay. Can you see my screen now?
No, we are seeing you. Okay, now maybe, what is written? Okay, now we see your screen, hold the screen. Try to present like that.
Okay, now? Now it's full screen? Okay.
And what is it, technician?
Sashko,
yes,
you must make presentation in this format.
Okay.
This small slides in the left side, you can put in left to got new poster from presentation. At this border, put in the left line.
The left.
You can stay in the line, vertical, no opposite. This excellent.
Okay. Okay, but this presentation will be about retrograde approach in peripheral vascular interventions. And I will start my presentation. I hope that this will go okay. I will remove this. Our experience in peripheral interventions. Around 8 years ago, Dr. Fari started endovascular program in Bulgarian Cardiac Institute. And this is the result 8 years later. 7 hospitals in 6 cities are part of Bulgarian Cardiac Institute, and more than 800 PTAs are performed every year. This is teamwork, modern treatment of peripheral arterial disease is teamwork of vascular surgeons and endovascular specialists. In our centers, patients are sent by vascular surgeons after non-invasive evaluation of peripheral arterial disease. And most of the patients are with chronic peripheral arterial disease. Around 20% are with critical limb-threatening ischemia or acute limb ischemia. Depends on clinical manifestation and vascular anatomy. Every case is discussed and best treatment is offered to the patients. So equipment is very important. You need to have a good machine, good materials, and after that, a lot of experience with peripheral interventions. But now, after you start your program, experience will come later. About retrograde approach, when to go retrograde? First, when we have failed antegrade access as secondary approach, this is in 15 to 20% of cases. And we can go retrograde in challenging antegrade cases in morbid obesity, osteograin anatomy, and CTOs as primary approach. But first of all, in most of the case, we try to recognize first antegrade, and if we cannot succeed, we can go retrograde. Access site for retrograde approach, most simple and often retrograde approach is femoral approach for treatment of ipsilateral iliac lesions. Second is distal superficial artery, popliteal, anterior tibial, posterior peroneal, and we can go retrograde transplantar or transcollateral. And I have one interesting case. I will show you the last. It's very interesting. You will see. Complication rate in retrograde approach is total 11%, and puncture related is 9%. Most of complications are related with the popliteal approach. So this is access sites. Common femoral artery, we can go retrograde and antegrade from common femoral. Superficial artery, distal superficial, we can see here, and proximal superficial, popliteal artery, anterior tibial, posterior tibial, and also we can use peroneal artery for retrograde approach. This is distal SFA access. We have experience with this access, and we use often for CTOs when we cannot pass through the lesion antegradely. Patient is in supine position. Puncture can be done with fluoroscopic, with the help of roadmap or ultrasound guidance. For popliteal access, direct popliteal artery access was introduced as an alternative treatment strategy in the treatment of CTO in combination with antegrade common femoral artery puncture. Popliteal artery is punctured with the patient prone. Once the occlusion has been traversed, the patient is usually turned supine. We use the access infrequently. This is in less than 5% of cases. How to do popliteal puncture? Safest way is to use ultrasound guidance, or we can use direct fluoroscopy. If there is calcification of the artery, we can puncture the artery under fluoroscopy, or we can make a roadmap from upper axis, or we can push the wire from upper axis subintimally and to use as a marker. We use micropuncture needle and not more than 6 French. And often we go sheetless through popliteal. And about retrograde distal pedal artery axis, we can puncture retrograde anterior tibial, dorsalis pedis in the distal part of the anterior tibial or proximal anterior tibial, posterior tibial artery in the distal part or mid segment, and peroneal artery. I don't have experience with peroneal artery, but there is also a way to go retrograde from peroneal. This is illustration where we can puncture the anterior tibial artery, the posterior, and also the peroneal. So this is first case that I will show you. This is 64 years male with ulcerative wound of right field with critical limb-threatening ischemia. I hope that this will go now. Maybe we should wait. Okay. Here you can see proximal SFA. In the second movie, it will be distal SFA. Very complex case with occlusion of superficial, popliteal, anterior tibial, and posterior tibial artery. This case is very interesting. I hope that we can see the movies. No. Can you see something? Okay, this is distal SFA. Here we have popliteal artery. This is made by digital subtraction. In order to reduce the dose of contrast, we use digital subtraction. You can see here short of occlusion of popliteal artery and one big collateral. And below the knee, only fibularis patent. Anterior tibial and posterior tibial are occluded. This is fibular. On the left, you can see posterior tibial, and we cannot see anterior tibial artery in this picture. How we treat this case? So first we try to pass the lesion of the popliteal antegrade, but it was impossible. The lesion is also very calcified, so we decide to go retrograde through this collateral. The wire is supported by balloon 2.0 60, and we succeed to pass through collateral retrogradely to predilate this lesion. You can see here the wire, how it goes retrogradely. And after that, we put the wire antegradely, because through this collateral we cannot pass with a bigger balloon, and we need to finish this lesion treatment of this lesion with bigger balloon. So we passed with the wire antegradely, and we made this drug-coated balloon dilatation, and this is the result after the dilatation. The result is perfect. After that, we treat the lesions of superficial artery, and due to dissection, we put a stent in superficial artery. This is the implantation of the self-expandable stent. And after that, we start to treat the artery below the knee because this is critical limb ischemia. So we need to open as much as we can. So through the collateral from femoral artery, we pass to the anterior tibial artery, and this is a kissing wire in proximal tibial artery, anterior tibial artery. We succeed to pass with the wire. We made the pre-dilatation and dilatation with drug-coated balloon. And after we open anterior tibial artery, we go retrograde through pedal arch to the posterior tibial artery. So the case, as I told you, is very interesting. And after dilatation of posterior tibial artery, this is the result of trifurcation, perfect result. And on the next movie, you can see the final result. So almost every artery of the leg was occluded, and this is the result. We'll wait for it. We'll wait for it, and the result is perfect. So this leg was saved. You can see here, perfect result to all the vessels. This is another case. This case was done 1 month ago. And as I told you, it's a very interesting case because maybe you cannot see here, but there is a supera stent in the popliteal artery, and the stent was was occluded. So antegrade, we didn't succeed to pass inside the stent. That's why we puncture directly the stent, as you can see here. We puncture the stent and we put the wire retrogradely. After that, we made externalization of the wire. We have antegrade access and retrograde access. Externalization of the wire. We finished the procedure with balloon dilatation, and this is the final result. Let's see the next case. Okay, that's it. Thanks for your attention. I had another case in the presentation, but I don't know if you wait. I have case of primary retrograde approach, and it's also very interesting. Here is. So this patient is after aortofemoral bypass. So we have diagnostic procedure from radial approach, and you can see here the bypass. Iliac artery is occluded, external iliac artery is occluded. On the next picture, we can see diagnostic of the whole leg. Here you can see the bypass to common femoral artery, and there was a critical stenosis of the superficial artery. Patient was symptomatic with claudication. Here we can see that the anterior tibial and fibular artery are patent. Posterior tibial was occluded, so we don't have much options here for treatment of this lesion because there is a bypass to common femoral artery. Also, we cannot go crossover, we cannot make crossover, so we decide to go directly retrograde from anterior tibial artery, balloon dilatation, and this is the final result. Directly. So all of you, there are things that you are all radialists. I think that you will not have problems with this, with distal approach for peripheral interventions, but I think that you only need experience. Thank you for your attention.
Thank you, Sashko. Thank you for connection in your time. Excellent presentation. Any questions? You know, we started with peripheral procedure yesterday.
Yes,
And
yes. Congratulations.
Next year we will have more questions than now. Thank you again.
Okay.
And we will continue with additional presentation. This is our friend Nenad Božinović, and originally solving problem in interventional procedures by Božinović way.
Thank you very much for invitation to this meeting to ZASINC. It's my pleasure to be there. And I will talk today about retrograde CTO recanalization without externalization wire. If we don't have in our CAT lab externalization wire, that is a trick how you can resolve the procedure. First, percutaneous coronary angioplasty in humans performed by Andreas Grinting in 1985, 2 weeks before his death during airplane crash. And he said 2 weeks before the crash this sentence: the total closure is a real problem, and if we cannot solve the total closure problem, we will probably never really address the question. And in 2019, 2 documents appeared in for CTO recanalization, that is guiding principles for chronic total occlusion percutaneous coronary intervention, one global expert consensus document. I'm a part of this document, and it's my pleasure to be a part of this, and also one another percutaneous recanalization of chronic total occlusion consensus document from EuroCTO Club from 2019. Also, these 2 papers describe the step by step how we can enter the CTO and how we can resolve CTO recanalizations. And by definition, chronic total occlusion are completely occluded coronary arteries with thrombolysis in myocardial infarction 0, flow with an estimated duration of at least 3 months. Coronary CTO are relatively common and observed in 15 to 25% of patients on coronary angiography. And CTO prevalence is much higher among patients with the prior coronary artery bypass. And the typical feature of CTO is presence of collaterals. We found them in more than 90% of cases. And we have doctors who said to patients, you have collaterals, and that is enough for you. But if we have this on mind, the collaterals supply provides only perfusion pressure in the range of 30 to 40 millimeter degrees of and occluded territory. Pressure also leads to functional reduction of distal vessel size, which then leads to underestimation of the vessel dimensions during a recanalization procedure. They have capacity to preserve myocardial function, but will not prevent ischemia during exercise. This is most important due to a limited capacity on increased blood flow. And I have 2 cases for today. The first one is a post-CABG patient, which I perform with the retrograde wire escalation, one of the retrograde techniques, and then perform my trick for this recanalization when we don't have RG3 wire or R350. This is a starting angiogram of the right coronary with a lot of homocollaterals and the distal occlusion. This is a right oblique, and this is a left system with collaterals, epicardial collateral starting from the circ and the septals. You can see septal collaterals, but these collaterals are very tortuous. And I try on this case from the beginning as a retrograde procedure, because there was a few attempts before this one, and because of that I decided to start directly retrograde. And this is a Sion black wire and septal surfing. And you can see that this wire is going to the position of the distal right coronary. And that is a confirmation of this one. That I change my wire to the stiffer one, Pilot 200, and this wire going out of the blood vessel. Sorry. With Pilot 200. I have micro fine cross. I have fine cross here. How I can put the play on this? No. No. Neko da mi kaže kako ide ovde, kako mogu da pustim play. This is a micro fine cross following the Sion black, and after that I change for the Pilot 200 because Sion black is not don't have enough support for distal part of this CTO. And this is my position, my retro wire. I put the second guide, and then I try to perform antegrade preparation, but my wire, antegrade wire, I think this is Miracle 6 or Miracle 12, and this wire going to the wrong direction. And you can see there in store fluoro. Then I try to navigate my Pilot 200. Look at this. And this is small perforation with the antegrade system. And I navigate my Pilot 200 because there is a very tortuous blood vessel. A little bit back. And when I going up with the muddy retrograde wire, I consider that is in antegrade true lumen. You can see on this film that my retrograde wire is, but my fine cross is stuck here. I cannot remove. And then I going with my retrograde wire to the antegrade guide. That is a standard step of a retrograde procedure. And this is only a rendezvous when I when I put my BMW, my standard floppy wire, to the retrograde micro. In previous step, I trap my retrograde wire with antegrade balloon that allows me to bring my retrograde micro to the antegrade catheter, and that is a standard procedure. When I have RG3 wire, I pull back my retrograde wire and then only cross through the whole system with the RG3 and made the dilatation and stenting. But when we don't have this wire, this is one first step of this maneuver. I put my antegrade wire in the retrograde micro, and after that, kako da pustim ovo sada da ide play? Eto. Now my retrograde wire, my antegrade wire is in a retrograde microcatheter, and then I pull back my retrograde wire. I pull back my retrograde wire and push my antegrade wire through the whole retrograde system. And then if I don't have enough support, because I have there microcatheter and have antegrade wire, if I don't have enough support, I will put there a trapping balloon. And then is a key point of this procedure, of this trick, because at that moment we have a stabilized system, and if we have a very hard lesion in antegrade fashion, that not allowed to our antegrade system to going back to aorta and losing everything. And after that, procedure is standard antegrade procedure, and this is my microcatheter is protecting collaterals. There is my retrograde guide hanging in aorta, and this is antegrade system now with trapped in a retrograde guide. And after that, after stenting in this patient, put some DES 1 and 2, and this is my final result in this patient. This is another projection. And after that, I publish, I put that on LinkedIn, and some colleagues from different centers, Pier Francesco Agostoni from Belgium, and also Şevket Gorgolu from Turkey, mentioned this like Božinović trick. And after that, Şevket tip in, and after that, Božinović trick. And 2 days ago, I think, yes, 2 days ago, they perform CTO during CTO meeting in Turkey from Antwerp, and that also mentioned this procedure like Božinović trick. And this is in other case, I will publish that in some paper, but I will decide where I will send that because of impact factor. This is another case. Može ovo da radi? This is another case, and the right coronary occlusion, just cracks of the right coronary we can see on this film, and there is a good collateral here, but very tortuous, and I couldn't cross this collateral. You can see also the another one. This is epicardial collateral, and if we start everything with the septal surfing, And this is a result of septal surfing through the first septal, and I reached the distal bed of right coronary. And this is simply retrograde wire crossing, because this is not so long CTO period, I think 7 or 8 months. This lady has had acute myocardial infarction on the right coronary. And then I put another guide. This is some part of minimalistic hybrid approach when we put, but this is also for experience, always for experienced operators. When we put just another guide, and if we cross a retrograde, then we put another guide to finish procedure. And this is the same situation. I put my retrograde wire, but my fine cross is there. I put my retrograde wire first in aorta, then in Judkins right. And this is another story. I put my fine cross now is here. In a previous procedure, I was there with the fine cross. Now I'm with fine cross in a distal part of occlusion. And after that, I make tip in with my retrograde wire to the antegrade microcatheter. When I put my retrograde wire to the antegrade micro, then I push forward this microcatheter. Now I have a retrograde wire, this, and 2 microcatheters. This is a retrograde micro, and this is my antegrade micro over the retrograde wire. After that, I pull back my retrograde wire. I pull back my retrograde wire, then push antegrade wire. And in one moment, you will see I put my antegrade wire to the retrograde micro. And now it's Božinović trick again. I have my retrograde micro now with the antegrade wire in the retrograde system. And this is, mogu ponovo da pustim ovo. And now for the support, this is a retrograde balloon. No, this is next. This is a retrograde trapping balloon. So I have antegrade wire in the retrograde micro, and then trap both of them, retrograde micro and the tip of antegrade wire in the retrograde system with a standard classic trapping balloon. This is 6 French, this is 2.0 on 14 atmospheres, trap all that antegrade system now in the retrograde guide. And no extra money, 200 euros for RG3, and this is very safe, I think. After predilatation, I put some stents, small and then bigger balloon. And then I put small amount of contrast just to see where is a CTO segment. Then put some stents just to distal part on CTO. And there is my final result. And we will check that in the next 6 months. This is epicranial, and thank you very much.
Thank you, Dr. Božinović. Any comments, Fadi?
It's really very impressive as a decision to practically, as I understand, we are simplifying a little bit the procedure by this approach.
Yes, we are
without externalization.
We are not losing extra money
exactly
for externalization.
Exactly.
And I have with this I have my standard floppy wire, my working horse wire. And also, I have on the table 2.0 for trapping any fine cross in previous maneuvers. And if I don't have enough support with putting my wire in a retrograde system, I will trap that with 2.0 balloon in 6 branch, and this is totally perfect system.
Compliments, really it's a trick. Really it's a trick. Tips and tricks. Fantastic, okay. Thank you.
We will continue with ceremony, closing ceremony. We expect Professor Siniša Stojković to join us. Profesore, da li se čujemo?
Ja se nadam da se čujemo.
Čujemo se. Dobrodošli. Izvinite na čekanju koje ste, bez maske, na čekanju. Upravo smo na završnoj ceremoniji da zaključimo da je ovo bio uspešan kongres. Molio bih vas samo za vaše kratko obraćanje skupu, s obzirom da...
Me čujete dobro? Me čujete?
Čujemo.
Hvala lepo. Evo ovde u sali iza, kao što vidite, ja sam u Istanbulu i uživo prenos upravo radi Fredi Galasi i ekipa. Treba i Nena da bude ovde, slušao sam njegovo izlaganje, šteta što nisam mogao da dođem, stvarno mi je žao, imam vrlo mnogo novih stvari i tako dalje da vam pokažem, ali prvo da se zahvalim na ljubaznom pozivu Vladimiru i na organizaciji i celoj njegovoj ekipi koja evo godinama već 7. put pravi ovaj vrlo ozbiljan sastanak koji je više nego zaživeo u Srbiji i regionu, rekao bih, vrlo ovako punih usta. Pre neki dan smo se čuli Vladimir i ja utorak i on otprilike kaže meni, sad se ja nalazim u onoj situaciji kao ti pre mesec i po dana, otprilike 100 mailova dnevno, ne znaš na koju će stranu svako ti postavi neko pitanje. Organizacija ovakvog skupa je fantastična i vrlo teška, vrlo naporna, tako da na tome zaista čestitam i to je veliki napor i mislim da ste uradili veliku stvar što ste ga održali, što je ove godine ponovo vraćen uživo, hvala Bogu, uprkos ovom COVID-ovim teškim vremenima. Zaista čestitke još jedanput na organizaciji, sa druge strane pogledao sam dobro program, nekoliko puta sam se uključivao, slušao sesije, zaista impresivno, od interventne osnovne kardiologije prešli smo na nešto što je postalo generalna kardiologija, uključujući i farmakoterapiju, uključujući i aritmiju, uključujući različite oblasti, srčanu insuficijenciju, hipertenziju i tako dalje. Na tome čestitke, na jednom sveobuhvatnom pristupu, na jednom odličnom programu, na onome što je savremeno i što je novo u kardiologiji. Nadam se da ste imali dobar paralelni program, dobio sam nekoliko inputa koji su vrlo pozitivni. Još jednom sve čestitke i pozdrav od mene, a vidimo se u nekoliko dana u Beogradu ponovo, pa ćemo se dogovoriti šta ćemo dalje sa udruženjem kardiologa koje zdušno podržava ZASING sve ove godine. Hvala vam lepo.
Profesore, hvala najljepše, hvala na vašoj ličnoj podršci svih ovih godina, hvala na podršci sa pozicije predsjednika Udruženja kardiologa Srbije. To nama jako znači, svaki mali korak napred je u stvari veliki progres za sve nas zajedno. Hvala još jednom, samo bi napravio jedan kratak referat, 116 planiranih predavanja, samo 4 nisu realizovana, imali smo 2 dodatna, brzo smo uspeli zahvaljujući tehnici da se organizujemo i da to uradimo. Imali smo 2 uživo prenosa, very successful case with Professor Osijev in Cath Lab in Zaječar yesterday. Thank you for that. And Dr. Božinović like assistant in this procedure. The second case was first peripheral case in Cath Lab in Zaječar from Dr. Fari and our friend Dr. Oktay. This was very successful too. Thank you for collaboration and for help us. Dragi prijatelji, ovim bismo završili ovaj kongres. Još jedan uspešan. Sljedeće godine, kao što smo rekli, očekujemo od 1. do 3. decembra na istom ovom mestu u istom ovom sastavu, dobrodošli ste. Sada bih vas pozvao na zajedničko fotografisanje u holu hotela i posle toga kasni ručak ili rana večera. Zahvalio bih se ovim divnim momcima iz tehnike koji su mnogo gorkih pilula progutali ovih dana, ali su muški sve ovo izneli zajedno sa našim Jolićem i našim Ivanom, tehničarem, odnosno inženjerom, izvinjam se. Zahvaljujem se ljudima iz medije i iz Pixarta. Hvala još jednom.